Hello everybody and welcome to today's masterclass about schwannomatosis. First of all, I want to thank CTF for the invitation and for giving me the opportunity to speak about a very relevant topic in the field of neurofibromatosis. My name is Said and I lead the NF Center in Hamburg, Germany. You can find my mail address down below in case you have questions later on. Today, I want to draw your attention on clinical parameters that help to distinguish NF2-related and non-NF2-related schwannomatosis. As you all might know, the nomenclature was renewed this year to stay abreast of important changes made in this field in the recent years. And although this might be confusing when new to this field, I will show you in the following talk why these changes are of importance and what relevance they have in the clinical setting. These are my disclosures. What I want to introduce you to is the eye for details. In this picture, you see two black and yellow colored and striped insects that might be mistaken at first sight. By a closer look, indeed, you will soon recognize the upper one as a wasp, it is a German wasp, and the lower one as a beetle called Clitus areatus, also known as a wasp beetle. So this was easy. But what now? Here you see that reality is much more complex and you might mistake some of these insects as a wasp even after a very close look. In fact, none of these, except the one in the upper left, the German wasp, have a sting, which is, I hope you agree, a very important detail. Same thing in phacomatosis, or NF in special. So here is what was true for a very long time. There was NF1, NF2 and schwannomatosis. The years date the time the first description was made, and please be aware that even NF1 and NF2 were still and sometimes can be mistaken. But surely the decoding of the genetic mechanisms in the 80s and 90s shed light to the mechanisms defining these two as completely different entities. Things got complicated when schwannomatosis was named as an entity of its own. The genetic mechanisms are not as clear-cut as in NF1 and NF2, and still there are question marks regarding this issue. So to recapitulate this quickly, here are the Manchester criteria for NF2. Hallmark are the bilateral vestibular schwannomas, but you will also find subcapsular cataract, meningiomas and peripheral schwannomas in NF2. Another criterion, of course, is the family history of NF2. But you might have realized that the genetic testing is not part of the diagnostic criteria, so the diagnosis was made clinically with genetics confirming the suspicion. Moreover, glioma and neurofibromas were part of the diagnostic criteria, but not in later revisions as they are not specific for NF2. Mosaic conditions, however, were not being taken into account. This diagram gives you the phenotypical spectrum of NF2. And being aware that these symptoms evolve over time and are not completely present at birth already points out that there is phenotypical overlap to other schwannoma predisposing syndromes, especially, and this is not a rare occasion, when NF2 is present as a mosaic condition and there is no detectable pathogenic NF2 mutation in blood. Here the clinical details become important, especially the ocular symptoms, namely cataract, epiretinal membranes, and retinal hamartomas, and the intradermal schwannomas are very specific for NF2 and show up quite early in life. So in some cases, these discrete clinical features are of high importance. I just mentioned mosaicism in the recent slide. Why mosaicism is so important in the context of schwannoma predisposing syndromes can be understood if we look at the molecular mechanisms of schwannoma formation. NF2 mutations are common in schwannomas and represent the common final path of schwannoma formation, but by no means this is a proof of NF2. Schwannomas can be found sporadically without an underlying constitutional mutation, and also in other syndromes, schwannomas can be part of the phenotype, such as Carney complex, hereditary neuropathies, or vaginal leiomyomatosis. In the upper row, you can see the typical case of a constitutional mutation. Different somatic mutations lead to loss of heterozygosity, called LOH, and development of, for instance, schwannomas. The second row shows a healthy embryo that gains different somatic mutations. some with subsequent LOH. In this case, a segmental phenotype is resulting, but also mild generalized phenotypes are possible. In the lower row, there is just a single somatic mutation, followed by a second one in the same cell line. This, for instance, is the case in solitary plexiform schwannomas or neurofibromas. Eric Legius will have a talk on the details regarding the genetic mechanisms. What I want to emphasize here is that the diagnostic criteria can be challenged by these conditions, resulting in two consequences. First, ideally negative genetic testing in blood is followed by tissue testing in the tumor, in two different separated specimens. Development of more specific clinical tools to differentiate genetically not classifiable symptoms. This resulted in the just newly developed nomenclature that names schwannoma predisposing syndromes as such and adds the proven or postulated genetic mechanism. This is why NF2 becomes NF2-related schwannomatosis. Some criteria of the Manchester criteria, like glioma and neurofibromas, have been cancelled as they are not specific for NF2-related schwannomatosis. Moreover, major and minor criteria have been named, and the genetic analysis is now an integral component of the diagnostic criteria. Also, mosaic conditions have been taken into account. Therefore, it was consequent to rename the diagnosis as the clinical spectrum is wide. Here, you see the typical cudgel-shaped vestibular schwannomas in a patient with NF2-related schwannomatosis that already led to brainstem compression. If you find two vestibular schwannomas in a patient, chances are quite high that this is NF2, or in the new term, NF2-related schwannomatosis. But this is not 100% sure, as bilateral vestibular schwannomas have been described in non-NF2-related schwannomatosis as well. This is also plausible that by pure stochastics that might even be possible sporadically. Again, this underlines the need of consequent genetical and clinical workup. Of course, the multiplicity of intracranial tumors, here you see different cranial nerve schwannomas and meningiomas, is very suggestive for NF2-related schwannomatosis. But most of these symptoms may be detected later in life. Challenging is to tell the right diagnosis in incomplete conditions or early in life. Still, these tumors are not specific for NF2-related schwannomatosis, and this is a problem because risk stratification, treatment options, and, very important, genetic counseling depends on the right diagnosis. Even more specific for NF2 are ependymomas that often are localized in the spinal cord in NF2-related schwannomatosis. These tumors affect about 1/3 of patients with NF2-related schwannomatosis and can be extensively affecting the whole spinal cord. Mostly these tumors are WHO grade 2 and benign in their growth pattern, but can lead to severe symptoms when progressive, especially in combination with a pre-existing neuropathic condition. However, the absence of ependymomas is not proving non-NF2-related schwannomatosis. On the left side you see a high-resolution MRI of the thigh, with a T2 hyperintense schwannoma in the ischiatic nerve. These high-resolution MRIs, called MRI neurography, are not only able to detect tumors but to illustrate the fascicular architecture. What is also present in NF2-related schwannomatosis are so-called microlesions. These small intrafascicular schwannoma-like lesions represent Schwann cell onion bulbs, indicating repetitive de- and remyelination, a putative origin of schwannoma formation. However, these are not specific for NF2 and can be found both in schwannoma predisposing and other neuropathic conditions. In mildly affected patients, they indeed do play a role in formulating the clinical diagnosis. Not only mosaicism is complicating the diagnostic approach to NF2-related schwannomatosis. There is also a genotype-phenotype correlation, with truncating mutations mostly causing more severe phenotypes, called Wishart phenotype. In the less affected patients, called Gardner phenotype, the more specific symptoms, such as neuropathy, ependymomas, and multiple intracranial tumors, can be absent or develop later in life. Finding the right diagnosis is obviously easier in more severely affected patients. So here are the original diagnostic criteria for schwannomatosis, non-NF2-related schwannomatosis to be specific. The age limit indicates that below a certain age, the clinical hallmarks of NF2-related schwannomatosis still have a chance to develop. But there are other limitations as well. First, schwannomas are quite common as solitary tumors. Often it is not obvious at first sight if there is a schwannoma predisposing syndrome underlying. And even if multiple peripheral schwannomas are evident, it is not specific for a single syndrome. I mentioned them before. Moreover, histologically the schwannomas cannot be used to differentiate NF2 versus non-NF2-related schwannomatosis. So here it becomes clear that the differentiation of non-NF2-related schwannomatosis and NF2-related schwannomatosis can be extremely difficult, especially regarding mosaic conditions or mild phenotypes. What makes things even more complicated is that somatic NF2 mutations are also present in non-NF2-related schwannomatosis. Moreover, there are different genes that can cause, via constitutional mutations, very much similar phenotypes of non-NF2-related schwannomatosis. First, SMARCB1 was described that can cause schwannomatosis, but also rhabdoid tumor predisposition syndrome. Recent studies indicate a genotype-phenotype correlation with non-truncating mutations causing more likely schwannomatosis. However, SMARCB1-related schwannomatosis seems to be associated with malignomas, something that is of high relevance in the individual risk stratification. ALSA-TR1 was described some years later. Again, constitutional mutations in ALSA-TR1 are not only causing schwannomatosis, but have also been described in Noonan syndrome or Noonan phenotypes. Malignancy probably are not linked to ALSA-TR1-related schwannomatosis. Both genes are located on chromosome 22. In contrast to pathogenic NF2 variants, constitutional mutations in SMARCB1 and ALSA-TR1 are not fully penetrant, even if described as a pathogenic in other patients. Other genes have been postulated to play a role in the development of schwannomatosis, such as DGCR8 or CDKN2A. But also other yet unknown somatic driver mutations are possible. So altogether, this explains that schwannomatosis is not only a single entity, it is a clinical and genetical spectrum disorder that was taken into account with the new nomenclature. This table shows that only a subgroup of schwannomatosis can be classified due to current genetical entities. In almost 15% of familial cases and about 60% of sporadic cases with schwannomatosis, no underlying genetic mutation in the genes ALSA-TR1 or SMARCB1 can be found. This could be due to a higher rate of mosaicism, but also other possible genes that play a role in schwannomatosis. This questions schwannomatosis as a single entity and explains why we should act on the assumption of a spectrum disorder. With this in mind, a more step process was hypothesized for non-NF2-related schwannomatosis and tumor formation. In this three-step 4-hit model, different genes on chromosome 22 are affected. After the germinal mutation, in this case SMARCB1, different changes on both chromosomes happen. Loss of one chromosome 22 and mutations or deletions of the remaining SMARCB1 and NF2 gene. This is why different NF2 mutations can be found in different tumors of the same patient with non-NF2-related schwannomatosis, indicating that this is not the underlying germline mutation. However, it is a crucial step in the process of tumor formation that shares steps with schwannoma formation and NF2-related schwannomatosis. This leads to a multi-step testing strategy to genetically approach the classification of schwannoma predisposing syndromes. As mentioned before, ideally 2 or more tumors should be tested if no constitutional mutation can be found in blood. Depending on the somatic mutations and maybe constitutional mutations, these entities have been described as either full or mosaic NF2-related schwannomatosis, full or mosaic ALSA-TR1-related schwannomatosis, full or mosaic SMARCB1-related schwannomatosis, 22q-related schwannomatosis, or if no mutation was found either in blood nor in tumor, schwannomatosis not elsewhere classified, or if no genetic testing was performed yet, schwannomatosis not otherwise specified. As I mentioned before, intradermal schwannomas and ocular symptoms, as well as spinal ependymomas, are very specific for NF2-related schwannomatosis. So what is specific for non-NF2-related schwannomatosis? Looking at clinical studies addressing this issue, a ton of possibly related symptoms can be found in the literature. Some of them are in the spectrum of NF2, some even in the clinical spectrum of NF1, and many are unspecific. Especially, the concomitant presence of other tumors has been described. The low incidence makes statistically significant associations hard, but besides all, the absolute hallmark sign in clinical descriptions of schwannomatosis, to be specific non-NF2-related schwannomatosis, is pain. Here is an example how difficult this topic can be in clinical setting. This 20-year-old male patient presents with a unilateral vestibular schwannoma, but without any hearing loss, and spinal schwannomas in the lumbar spine. Yet there is no surgery done and no histology. All genetic testing was negative in blood. The patient suffers from intermittent pain in both arms and chronic depression. Interestingly, one of his children has a pathogenic LCTR1 mutation in blood, but no symptoms yet. Taking into account that these mutations do not have a full penetrance, it is not proving the non-NF2-related schwannomatosis in this patient. Both is possible: mosaic NF2-related and non-NF2-related schwannomatosis. In this second case, a 57-year-old woman presents with a unilateral vestibular schwannoma with slight hearing decline, peripheral schwannomas and myxomas, and two constitutional variants in both the NF2 and LCTR1 gene. With attention to the myxomas, even Carney complex is possible, where mutations can be found in the PRKRA1 gene. So you see, this resembles a common problem, and in fact, this affects genetic counseling and risk stratification. In the following slides, I want to draw your attention to easily accessible clinical features that can help to differentiate between both entities. First of all, as I mentioned, pain is a central manifestation of non-NF2-related schwannomatosis. On the other hand, pain is a very common and unspecific symptom that is not necessarily related to the underlying syndrome. By using specific but still very simple questionnaires, here pain detect, the neuropathic character of pain, which is typical for non-NF2-related schwannomatosis, can be detected. This is our cohort of patients. Almost all schwannomatosis and NF2 patients filled out the questionnaire. It is quite obvious that pain is quite uncommon in NF2, and that the a priori chance of schwannomatosis, in case of a painful neuropathic condition, is high. Here I summarized neuropathic features of NF1, NF2, and non-NF2-related schwannomatosis. As you can see, neuropathy affects only a small subgroup of NF1 patients, mainly in case of nerve compression. In NF2, a sensory motor, predominantly axonal neuropathy, independently from tumor formation is common, especially in full-blown Wishart phenotypes, whereas sensory or motor deficits are uncommon in non-NF2-related schwannomatosis. In non-NF2-related schwannomatosis, both tumor-dependent and tumor-independent painful conditions are possible. This led us to look for clinical tools that address this issue. By using routine neurophysiological assessment combined with a computerized algorithm, the number of intact motor units of a muscle can be determined. This is called motor unit number estimation, or MUNE. After maximum stimulation above the threshold, the stimulus current decreases in small steps, resulting in lower compound muscle action potentials. You can see this in the left figure. The lower the number of motor units, the bigger are the leaps between the compound muscle action potentials of two different stimulus intensities. Compare row A, B, and C. Even more significant is the size of each motor unit. If you look on the third column of the left figure, you realize that the biggest motor units in A are about 0.1 millivolt. In C, a neuropathic condition in NF2, the size of the biggest motor unit is almost 10 times its size. Due to axonal sprouting, the remaining motor units become bigger, compensating in part for the axonal loss. In summary, this method is able to detect axonal damage far before clinical symptoms occur or even measurable by routine neurophysiology. Comparing NF2 and non-NF2-related schwannomatosis to normal controls, look at the picture on the right, shows a wide range for NF2 with generally distinct reductions in motor units. The schwannomatosis cohort is just in between controls and NF2. Severe reduction, however, cannot be observed. Another method aiming for detection of neuropathic symptoms is the intraepidermal nerve fiber density, called INFD. By taking a small, about 8 mm, punch biopsy just 10 centimeters above the lateral malleolus, the small intradermal C fibers can be microscopically visualized. C fibers are the smallest unmyelinated pain fibers that vanish from the epidermal layer in painful neuropathic conditions, so-called small fiber neuropathies. Clinically, this leads to hyperalgesia, allodynia, or burning feet, in some cases even to neuralgiform attacks. The density of the fibers can be quantified and works as a surrogate for painful neuropathic conditions. There are age and sex matched reference values existing, and in recent years this method became a standard diagnostic tool for painful neuropathies. By comparing NF2 with non-NF2-related schwannomatosis, a significant difference can be observed. Matching differences in phenotype, a significant reduction in intraepidermal nerve fiber density can only be observed in non-NF2-related schwannomatosis. This difference is remarkable, as both entities share morphologically identical peripheral schwannomas and microlesions. By the way, both above-mentioned clinical cases had a highly significant reduction in the intraepidermal nerve fiber density. This leads to the question whether neuropathic changes are caused by tumor formation or by the gene defect itself. Indeed, there is proof of loss of the axonal integrity in NF2 knockout mice, which would be plausible because myelin, the gene product of the NF2 gene, plays a role in the axonal transport. However, if this is true for non-NF2-related schwannomatosis is unclear. I'll come back to this question a few slides later. Also, imaging methods can be used to detect features of schwannomatosis that are not clinically detectable. Those intravascular hyperintense lesions can be found in high-resolution MRI neurography, matching the ones found in NF2. Interestingly, we found these microlesions also in unaffected limbs of segmental schwannomatosis, suggesting mosaic mechanisms leading to generalized microlesions on one hand and segmental schwannoma formations, called macrolesions, on the other hand. We even had two patients with constitutional pathogenic Alzheimer1 variants and segmental schwannomatosis. This is how MRI neurography adds to the clinical spectrum of schwannomatosis. However, it is not possible to differentiate between NF2 and non-NF2-related schwannomatosis only by imaging characteristics. These microlesions can also be found by a high-resolution nerve ultrasound imaging, a method that is much easier accessible than MRI neurography. In some cases, lesions can be detected that are missed by MRI and vice versa. What is also accessible is the cross-sectional area of a nerve, a parameter that is routinely used for compressive neuropathies such as carpal tunnel syndrome. Interestingly, There is no correlation between the cross-sectional area and the number of microlesions. There is also no correlation between the cross-sectional area and the number of motor units. The fact that microlesions are present both in conditions with and without axonal loss, namely NF2-related and non-NF2-related schwannomatosis, makes this plausible. Moreover, it makes it unlikely that microlesions are the reason for neuropathic changes. Maybe they represent an unspecific feature for nerve dysfunction, and the neuropathic changes do not develop in association of compressive lesions. What speaks against this hypothesis is that in many patients pain relief can be achieved by surgically removing little schwannomas. At least in some patients, the pain condition is completely independent from detectable schwannomas or microlesions. But not only the peripheral nerves show distinct features in both entities. Also the dorsal root ganglia are of interest. On this slide you can see normal dorsal root ganglia in a patient with non-NF2-related schwannomatosis on the left side. On the right side is a patient with NF2. This patient shows a generalized hypertrophy of his dorsal root ganglia. Histologically, in a postmortem analysis, this is caused by grouped areas of Schwann cell proliferation, a process that may be independent from tumor formation. Taken together, the characteristics of neuropathic features help to distinguish between entities of the neurofibromatosis spectrum. While NF1 shows only little neuropathic features, NF2 exhibits a preponderant painless sensory motor neuropathy that might become early symptomatic in severe phenotypes by weakness, sensory deficits, and gait disturbances. In non-NF2-related schwannomatosis, these symptoms are rare, while neuropathic pain is predominant. These findings can be valuable tools or at least surrogates and help in genetically indistinguishable cases. So we can recap that in many cases a clinical diagnosis is possible, especially in full-blown phenotypes. Genetic analysis helps to verify the diagnosis and differentiate in uncertain cases. When both fail to name a distinct entity, further clinical tools can be used to formulate a presumptive diagnosis. This might still be very helpful in treatment and risk stratification. Having in mind that the genetic background still is not fully resolved, we have a long way to go. Maybe we have to readdress this again and again until the exact mechanisms and etiology of schwannomatosis and schwannoma formation are resolved. I appreciate your interest and patience, and I'm happy to answer your questions. Thank you very much. I also want to thank my patients who participated in the studies and allowed to show clinical pictures of them. Last but not least, I want to thank my team in the lab and in the clinic, and all partners and collaborators, as well as the CTF and the German lay organization Bundesverband Neurofibromatosis. Thank you.
Hello everyone, and welcome back to the Info Master classes, and thank you very much, Saeed, for this very nice lecture. We have a very, very shy audience today who don't ask very many questions. So please, everyone, do come in with your questions in the chat or in the Q&A box. We have, however, one question from Anna Bakker, who asks, schwannomatosis patients often suffer from episodes of excruciating pain. And are you aware of measurable systems to measure this pain?
Yeah, that's a very good question, because pain is a very individual symptom, and you may find patients who have severe pain, but they are very stable, and they are very and they don't want to take painkillers or something else. And the other ones, they are very desperate and want to have surgery. So an objective measurement for pain is almost impossible. We try to use clinical tools like laser evoked potentials that measure the C and A delta fibers, which are quite good, and we found that they are faster in schwannomatosis, which led us to the hypothesis that if patients with non-NF2-related schwannomatosis lose their C fibers, their pain fibers, maybe the delta fibers are leading more faster, and that leads to somehow central plasticity that aggravates the pain. So the broadly or mainly used pain measurement is the numeric rating scale, or like some sort of visual scales, which work quite good. But more important is the individual burden of pain. And most patients with schwannomatosis need to have either some kind of pain medication or maybe surgery.
Thank you. And another question from Annette, still on pain. Regarding pain assessments, do you think that wearables could be used by patients in order to try to understand and categorize their pain a bit better? There's a lot of talk of, you know, these wearable devices being useful in many diseases.
Like maybe to rate pain in real time and
exactly.
Yeah, and they're also
measure pain somehow.
Yeah, and there are also quite good apps existing that measure pain, or when where a patient can rate their pain scale. And to my experience, it is quite good. And I often tell them to write a diary or something else, because with some time going by, they don't remember how severe the pain was in comparison to like prior to medication or prior to surgery. So this is something we are very desperate for, to have a very profound and good and reliable pain measurement system. And I think these wearables or apps are working very nicely.
Thank you. I also wondered if you could tell us a bit about what the treatment options for non-NF2 schwannomatosis patients are at the moment.
So as I mentioned, we found proof that there is a correlate of the pain is a C fiber dysfunction. So we can really speak of a small fiber neuropathy. And in my experience, regular painkillers like aspirin or paracetamol don't work quite good, and even opioids are not working for a long time. We use co-analgetic substances like gabapentin, pregabalin, or amitriptyline, which work quite good, but also can lead to some side effects like a dizziness and brain fogging. And in a subgroup of patients, we observed that surgical treatments work very well. So even the resection of very small subcutaneous tumors can lead to a prolonged pain relief, which is not always plausible by neurological terms. That we don't think we can relieve the patient from pain just by a resection of a small intradermal schwannoma, but it is so.
So regarding this, because the only option to remove the schwannomas, and I'm not talking about the pain, but the only option to remove the schwannomas at the moment is surgery, isn't it?
It is, yes. There were studies trying if bevacizumab, which works for NF2-related schwannomatosis, for the vestibular schwannoma, could also help in non-NF2-related schwannomatosis for the peripheral ones. But there wasn't a very sufficient effect. And so the only option today is surgical treatment. But of course, some of the schwannomas are on the big nerve trunks, and it's not always easy to resect them completely without any damage of the peripheral nerves. So it should be a surgeon with a very good experience of resecting schwannomas in those syndromes. And some patients even have a a very high tumor load. So we should really think about which tumor has to be resected and which one to leave.
And is it has it ever happened to you in your practice that there was a schwannoma that could not be removed because it was too dangerous to do?
Yes, we observe this sometimes, and we also have this subgroup which where surgery leads to even more pain. It was something we discussed some years back very frequently. Now I would say most patients can be helped by surgery, but there is a subgroup which tells about more pain after surgery. And I would say in the peripheral nerves, most schwannomas can be resected quite good, but when they are centrally or near the plexus or in the spinal schwannomas, it can be very difficult. But of course, I'm not a surgeon. I always in Hamburg we have an F board where we always discuss those patients together with the radiologists and the neurosurgeons to get the best result for all patients.
And just to give the audience an idea of the entity of the problem regarding non-NF2 schwannomatosis, you are running one of the biggest centers in Germany regarding non-NF2 schwannomatosis, and I assume that the health system ends up directing many patients to your center. How many patients do you actually follow, roughly, that have non-NF2 schwannomatosis?
So we are a quite big center, and our department is only working on neurofibromatosis, so NF1, NF2, and schwannomatosis, and rarely some other phacomatosis. And we do see between 1,200 and 1,500 patients a year, which are mainly NF1 because it's much more frequent. And I would say we see about 3 to 4 schwannomatosis patients a month. Some of them we see on a very frequent basis because they have pain and they have to be followed quite closely. And our complete cohort are about, I would say, 50 schwannomatosis patients. But to my experience, it is very much overlooked because we sometimes detect by chance patients who have underwent surgery for one schwannoma, and then they say, I have other bumps as well on the skin, and we see like 3 or 4 schwannomas. And when we do MRI or even MRI neurography, we see the full picture of schwannomatosis, and they may not have this kind of severe pain we are experienced of. So I think we don't see all schwannomatosis patients, but we see a very high rate of NF1, for example, because it becomes very obvious very early in life. So there is a lack of diagnosis in schwannomatosis, in non-NF2-related schwannomatosis.
And how important do you think it would be to do, massive tumor biopsies for the field, just for the understanding of the biology of non-NF2 schwannomatosis tumors?
I think it's not important for the treatment itself because when there's pain, we know we have to treat the pain, and when surgery is not feasible to relieve the pain, we rely on pain medication. But as I said in the talk, it's very important to have the diagnosis fixed. So to discriminate NF2 and non-NF2 related schwannomatosis, it can be very important. And for many patients, it is very important for a genetic counseling. They really want to know if they have NF2 or non-NF2 related schwannomatosis and whether they can inherit it to their children. And in those cases, when we don't find any germline mutation and there are good accessible peripheral tumors, we think about doing a biopsy or even a surgery to remove those tumors, and both to histology and genetics from those tumors. And by chance, we get like two same NF2 mutations, and then we know, okay, it's mosaic NF2 related schwannomatosis, or we see a different NF2 mutations and we can say it's non-NF2 related schwannomatosis.
I see. And do you have many cases coming to your center which have been misdiagnosed as something else? Misdiagnosed as an NF2 and being referred to your center for NF2, and then it turns out it's not an NF2, but it's a non-NF2 schwannomatosis. Does that happen?
That's a quite common problem in NF in general, because still I observe that NF2 and even NF1 are misplaced, and many symptoms from NF1 like cafe spots, neurofibromas are interchangeably used for NF2 as well. But we also sometimes have patients who like have any skin diseases and then come to us under the suspicion of phacomatosis, which is not present. But we more and more also see syndromes like Carney complex, where they can have schwannomas and myxomas, as I told in the second case. So I think the look for clinical details is extremely important to, even for us, where we mainly treat neurofibromatosis, not always have the suspicion that only NF can be present or schwannomatosis can be present, then to also look for Leopard syndrome, Noonan syndrome, CFC, or Carney complex.
And the audience is still very shy. They typically have lots of questions. Oh, there is a question from Anna Grisold. Do you schedule your follow-up MRIs in head and or spine regularly for patients with schwannomatosis, for example, yearly, or just if the patients present with some neurologic symptoms?
No, I schedule them on a regular basis. I do them more frequently in NF2 patients who get bevacizumab because or with central nervous system tumors, and in the regular case of non-NF2-related schwannomatosis, where we have only peripheral schwannomas, I do MRI imaging regularly, yearly or every second year. We usually do whole body MRI, which is quite difficult in Germany because it's not part of the insurance. But we do cerebral and spinal imaging at baseline, and then if there are only a few tumors, we follow just those tumors. But I recommend doing whole body MRI at baseline also, and maybe all 3 to 4 to 5 years.
Thank you. I don't see any other questions. No. I was wondering, can you tell us when you think the latest, important discovery in non-NF2 schwannomatosis was made? According to you?
I think one very important detection was finding the alpha-1 gene, because it was proving that it is not only one gene or one mutation in one gene predisposing to the syndrome. It was almost the proof that there is it is a spectrum and maybe a polygenic syndrome. But I think we haven't understood quite well whether we talk about completely different entities or if it really is a spectrum from the same entity, like there is a multi-step process and in the end it is the schwannoma formation. And but I would say that detection of alpha-1 was a very big step to understand this.
And is there a clear understanding of, if it's the tumors that actually induce the pain, or if the pain is a separate mechanism that is independent from the presence of the tumors?
I would say the second one. It is still surprising that, as I told you, that removing some of the tumors leads to pain relief, but the very common case is that patients present with some schwannomas, just a few ones, like 2 or 3 or 4 schwannomas. I just had a woman this week who had schwannoma in the plexus on the right side and on her right hand, but the pain was in her feet and in her left arm. And this was something that made us look for tools like the MR neurography, where we thought there must be something else in the nerves or something, a mechanism that leads to this kind of small fiber neuropathy. We also see it on the far end of the C fibers, even in the skin, that they are reduced, that this is something that is mainly independent from those bigger tumors. And this is why surgical procedures alone will not lead to pain relief in all patients.
So yeah, so you reckon these two things are to be investigated separately?
Yeah, I think so. And we also did some biopsies of those micro lesions, and we found these onion bulb Schwann cells. And what was most surprisingly for us, we have some of these segmental patients where they only have schwannomas in like few segments of the spine or only in one limb, and we did whole body MR neurography, and we found those micro lesions all over the body. So if I had to say a very, like my own belief, I would say it must be a very a multi-step process, and maybe the first step was made in the whole body, which leads to micro lesions, and the second step was somatically. So a somatic driver leads to schwannoma formation and to a concomitant NF2 loss or a chromosome A22 loss. But the first step that leads to micro lesions is also the step that leads to pain. So I would say the diagnosis of a segmental schwannomatosis is something that we have to question if this is really existing as a whole, as an entity, and we have to question if segmental schwannomatosis is only caused by mosaicism or something else.
Mm-hmm. Thank you. We have a question from the audience, from Sage Green, who would like to know your thoughts on the use of MEK inhibitors for the treatment of NF2 schwannomas that are not amenable to surgical resection without great morbidity.
There are no descriptions yet, and like just from the pathogenic pathway, I would think that it will not work. There were studies on mTOR inhibitors, which didn't work very well, and reducing those tumors in size, I would question if this leads to pain relief. I don't think so. I think the mechanism that leads to pain is not due to the tumor size, because we don't observe any kind of weakness or sensory symptoms in schwannomatosis patients, only if a tumor becomes compressive, and this is quite rare. So the pain mechanism is independent from the sensory motor neuropathic mechanism.
We have another question from, I'm sorry, I don't know what the first name is, from Mr. or Mrs. Aiton. Do you have difficulties in distinguishing somatic gene variants from germline variants in the tumor based on the variant allele frequency?
Yeah, sometimes we have frequency of about like 40% or 45%, and then becomes difficult. But usually when we find somatic variants, we find them in lower frequencies, so we can say it's a somatic mosaicism. And we always, like, if we investigate tumor material, we always investigate blood. Also, we never investigate tumor material alone.
I have a comment from Sage Green, and the question was actually the question on MEC for NF2 schwannomas was actually referring to the tumor, to the treatment of the tumor, not the treatment of the pain. So
that's like there are no like to my knowledge, I don't know if they have been experiences on MEC highs on schwannomas in non-NF2-related schwannomatosis. There have been trials with bevacizumab and mTOR inhibitors, which led to no like really good effect on the tumor volume. But even by changing tumor volume, I would doubt that it would have an effect on the pain. And the tumor volume only in rare cases is a problem in non-NF2-related schwannomatosis. We have those patients.
Sorry. The question was on NF2 schwannomas.
NF2 schwannomas. No, we don't have any experience with MEC inhibitors.
I've read a while ago, I mean, I've come across publications saying that MEC inhibitors could be used for NF2, but this was in very early preclinical settings. I suppose there is not yet any solid translational reason to translate it into the clinic.
Yeah. And because Merlin is not so close related to the RAS pathway, it is in some ways, but not so closely as an NF1. It was not something that was used clinically, to my experience.
Another question from Anna Grisold. How often do you see segmental schwannomatosis? And do you also follow up the affected segment with MRI ultrasound regularly, and in which time intervals?
Yeah, we see them in about almost 30%, so almost 1/3 of schwannomatosis are segmental schwannomatosis. As I said, I think much overlooked. They may be much more frequent. So I would hypothesize that non-NF2-related schwannomatosis is very often something that happens as a mosaic or as a segmental disease. And we follow them in the same intervals as the generalized schwannomatosis patients, because even in those, sometimes we don't find any mutation, and we don't have a threshold to say is it the full-blown phenotype if we only find a mutation in the blood, or if we don't find a mutation, it is mosaic, or when it's segmental. So we follow them tumor specific, and if a tumor is rapidly growing, we follow at closer intervals. If tumors are stable, we go to intervals from 1 to 2 years.
I don't see any other questions, but we still have some minutes left. So maybe I wanted to ask you, what typical age does a non-NF2 schwannomatosis patient show up in your clinic for the first time?
I think a typical age is quite high compared to NF2 and to NF1. It is very surely above 30 or 35 years. In most cases, between 40 and 60 years, with the most prominent symptom pain, whereas we see NF2 and NF1 patients usually in childhood or at latest in early adolescence. Rarely there's an NF2 patient. Like, we have some NF2 patients that show up later, but they are most likely mosaic.
And when it comes to familial cases of persons that have actually transmitted the disease to their children, do you also follow the children even though they're completely asymptomatic?
I offered a genetic testing if we found something in the blood by the index patient. If we found nothing, we don't do MRI on a regular basis because the transmission rate are lower when you say familial cases. So that if the parent generation was also affected and the index patient is affected, we clinically see those patients at one time, maybe in late childhood. If there's no symptom present, we don't follow them on a regular basis in non-NF2-related schwannomatosis. In NF2-related schwannomatosis, we offer brain MRI during adolescence or during childhood.
Yeah, because I mean, the clinical manifestations, you end up dealing with only with patients with very advanced disease, so to speak, when the disease has progressed so much that it starts to be truly symptomatic. I was wondering, you know, if in familial cases, the monitoring, I'm not saying submitting them to MRIs every 6 months, of course, that would be completely unjustified, but following these children more closely as to how you know how the disease evolves, because wouldn't that be something, you know, that would help the understanding of how to bring solutions?
It would help the understanding, and it would be of high interest if we could find, for example, micro lesions even in children. If we wouldn't find the micro lesions, it would be interesting because we don't know if they develop after the bigger schwannomas or before. But those investigations wouldn't have a consequence if there's no symptom, no pain, no neurological deficit. We wouldn't prescribe painkillers or wouldn't offer surgery. And knowing this, it is only relevant to those who really want to know if they may have inherited it. And if we don't find a mutation in the blood, we can't say anything about inheritance rates.
There's another question from Mr. and Mrs. Ayton. Do you ever do genetics testing in other tissues than blood or tumor if you suspect a mosaic?
Yeah, we do this, especially for NF1 from the Caffrelay spots. For non-NF2-related schwannomatosis, usually we use schwannomas because we can say we will find the genetic changes in the tumors. In NF2-related schwannomatosis, it is very interesting because, as I said in the talk, you can find those intracutaneous schwannomas, which are not present in non-NF2-related schwannomatosis. And these are very hard to identify. So sometimes when we see small intracutaneous changes, we offer to biopsy them and to do genetics from them.
Now, last question from Annette Backer. Our hour is done. She asked, who do you think she sees schwannomatosis patients first? Is it a neurologist or a GP? And do you have any idea on how to do outreach to the community regarding, you know, how to best diagnose non-NF2 schwannomatosis patients?
I'm very sure that it is very important to see those patients in the centers that deal with phacomatosis for many reasons. And one reason is that those very slight changes I talked about, especially in NF2-related schwannomatosis, which might be present at very young age, and if a GP is not familiar with them, he won't identify them. Like ocular changes, or even the very slight intracutaneous changes. And the second one is even if a GP identifies more than one schwannoma, it is very important to differentiate to NF2. So to look for those hallmarks of NF2 and to be sure it is not interchanged. So I would say every patient who has a suspicion of a schwannomatosis must be seen in a center. And I would also recommend that even a patient with a single schwannoma should be at least once seen in a center to be sure it is only one schwannoma and not anymore.
Well, our time is up. Thank you very much, Saeed, for this master lecture on the difficulties of actually understanding and distinguishing the two forms of schwannomatosis. And thank you to the audience for their interesting questions. This webinar will be is being recorded and will be posted on the YouTube channel as soon as possible. We have the next webinar will regard only pain in schwannomatosis. It's going to be held on the 22nd of November at exactly the same hour. And thank you, everyone, and hope to see you soon.
Thank you, Marco.